Welcome to this special episode of Diabetes Core Update, where we will discuss root causes of obesity, sugar, and strategies to decrease sugar in the diet. The context here is that we are in the midst of an obesity epidemic that is injuring health, longevity, and quality of life. The current rate of obesity among adults in the United States, based on new data from the CDC just released in September, is that over 40% of adults in the United States have obesity, and among adults 40 to 59 years of age, that number is over 45%. About another third of adults fit into the overweight category. One of the most important causes of obesity is the amount of highly processed simple carbohydrates in our diet, including sugar. Sugar and sugar derivatives like corn syrup are used and overused to make our foods highly palatable. Today, we're going to discuss this in depth with experts in the field so that we better understand what is going on and are better equipped to address this with our patients. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. Before we dive into this topic, let me share a word from our sponsor, Heartland Food Group, the maker of Splenda. Turning to the Splenda brand is an easy way to help your patients reduce sugar. Splenda allows people to enjoy their favorite foods and beverages while working to maintain a healthy weight or manage blood sugars. Splenda continually innovates new solutions to reduce sugar, including introducing Splenda Stevia, a zero-calorie sweetener grown by U.S. farmers, and Splenda Diabetes Care Shakes, a high-protein shake with no added sugar. Visit Splenda.com for a complete list of products and delicious recipes for your patients. Joining us today to discuss root causes of obesity and the contribution of refined carbohydrates to obesity is Dr. Vasanti Malik, who is an assistant professor and Canada Research Chair in Nutrition and Chronic Disease Prevention in the Department of Nutritional Sciences, University of Toronto, and an adjunct assistant professor in the Department of Nutrition at the Harvard T.H. Chan School of Public Health. Vasanti, welcome to ADA's podcast.
Hi, Neil. Happy to be here. Thanks so much for having me.
Also joining us to discuss public health aspects and approaches to obesity is Dr. Sandra Albrecht, Assistant Professor, Department of Epidemiology, and co-lead in the Food Systems and Public Health Certificate Program at Columbia University Mailman School of Public Health. Sandra, welcome.
Thank you for having me as well. Happy to be here.
Finally, also returning to our series of podcasts to bring it all together is Marina Shapiro, who is a registered dietitian and a certified diabetes educator and author who has a busy clinical practice, a wealth of experience advising people on practical ways to improve their nutrition, and who always kind of figures things out that I leave the podcast feeling like I've learned a lot. Welcome, Marina.
Always a pleasure to be here, Neil, and I'm excited for this conversation with these amazing hosts with lots of knowledge.
Thank you so much. Vasanti, I'd like to start by asking you if you can discuss some of the root causes of our obesity epidemic.
Absolutely. And this is such a critical question. So obesity is a complex condition with many interrelated causes that operate across different levels, right? So at the individual level, so we have our genetics, right? There's genes that predispose to developing obesity. There's also lifestyle factors, our diet, our physical activity, our sleep, these all work together. Course, and then we have broader sort of socioeconomic and structural factors and our living environments, which really determine the sorts of foods we have access to. And then, of course, our physical activity levels, right? So we know obesity is caused by consuming more energy from foods and beverages than we can expend through physical activity, right? So this is energy imbalance. And you mentioned in the introduction about over-consuming highly palatable foods and beverages. And this is absolutely what we've been seeing over the past decades, this sort of appearance and shift in the food supply where there's highly palatable foods we have that are easy to overconsume. And I think that's coupled with the change in our lifestyles that predispose to more sedentary activities, coupled with stress, poor sleep quality. These all kind of contribute to developing obesity, combined with genetics, and then of course epigenetics as well. So really a lot of factors that are working together to end us up to what we have today, which is this sort of pandemic, if you will, of obesity.
Now, Vasanti, you mentioned something that I've often heard the word but never really understood, epigenetics. Can you just say a couple of words on that?
Yeah, absolutely. And so this is a phenomenon where our environment, so foods that we eat, other environmental exposures, can change the expression of our genes. So they're not changing the DNA sequence, but they're changing the expression. So turning genes on and off, for example. And so we can see there was a study done on sugar sweetened beverages, for example, that was published in the New England Journal years back now, I think, it's in 2011 or 2012, that showed an interaction between genes and consuming sugar sweetened beverages, meaning people with certain genetics have experienced adverse effects of sugar sweetened beverages more so than others without that certain combination of genes. So really, it's the expression of genes that change in relation to certain environmental exposures.
That's so helpful because I've heard that term used a lot, and I think it's often, I've never heard it explained as well as you just did. Now, you mentioned a change in our physical environment. Clearly, we live in a more sedentary world. Translate that to we are burning less calories. Our focus of today is on what we eat and how that affects the consumption side. And I know evidence isn't always straightforward, but can you discuss our current understanding of where refined carbs, sometimes called highly processed carbs, and sugar is a part of that, how that fits into this story?
Absolutely. And so I think it's helpful to think about some of the historical trends that have taken place in the US and elsewhere. We know in the late 1970s, early 80s, dietary guidance was really focused on reducing fat, right? Reducing saturated fat, reducing total fat. It was a low fat craze of the 80s and 90s. And so what happened was, as intake of fat was going down, there was an increase in refined carb in the food supply, as well as reflected in consumption levels as well. And I'm not talking about whole grains, right? I'm talking about refined carbohydrate. So just so everyone's on the same page, refined carbohydrate is like a grain, like a whole grain that has the fiber and germ removed. So removing a number of micronutrients in those parts of the grain, just leaving like a starchy that's consumed. And when we remove the bran and the germ from the grain, we're losing a lot of the health benefits and we're left with this refined grain. And white flour, for example, is a refined carbohydrate, and we're finding that in crackers and all sorts of refined foods that we've seen increase over this time from the 1970s and 80s. And paralleling that change in the food supply, we've also saw the real rise in obesity and diabetes. And so that's temporal trends, right? And so we can't really hang our hat on temporal trends, but there's also evidence from epidemiological data and trials that support those trends. And so there's a number of studies that have shown adverse effects of consuming excess refined carbs as well as sugars on body weight as well as diabetes. And there's biological rationale for this, right? So if we think about refined carbs with not having that fiber, they're absorbed and digested very quickly. So you get this rapid rise in blood glucose. And so then we get the rise in insulin. And this over time can lead to metabolic aberrations, putting us on the path to developing cardiometabolic conditions. And so I think that's like a high level kind of explanation of where the refined carb story fits in. We know during this time as well, the 70s, the 80s, when we're seeing these products enter the food supply, the refined carbs, but also a lot of sugar entering the food supply as well. High fructose corn syrup became abundant in the food supply in and around that time as well. And we know high fructose corn syrup doesn't differ that much in terms of its composition compared to sucrose, which is table sugar. So both are supplying glucose and fructose in fairly similar proportions. But really, it's the overconsumption of these products that are leading to, I think, to adverse cardiometabolic health, particularly the fructose component that's metabolized in the liver.
That's so helpful to put that conceptual basis to what's going on. I believe it's David Ludwig who talks a lot about the carbohydrate insulin model of obesity. He had joined us, it's almost 2 years ago now, to talk about an overview paper he had in American Journal of Nutrition. And there's a lot of compelling research that supports that. Isn't that correct?
Yeah, there is. I think there is a lot of research on this, and I think understanding those pathways is certainly helpful, and it aligns with what we're seeing in the epi data as well. So I think really, really strong evidence across the different areas, from the clinical, from the epi, from the basic science as well.
Yeah, it's so important. When I hear that sort of thing, I actually think about a poem I heard a long time ago by a former poet laureate of the United States, William Stafford. It's short, don't worry. It goes, straw, feathers, hay, small things, yes, but when they all point in the same direction, you know which way the wind is blowing. And I think that's often the way we put science together. There often isn't one thing that gives us the answer, but when everything, and these are not small things, but when everything lines up, it can be very informative and points in the direction of truth. Having discussed those root causes and the effects of refined carbs, I want to turn now to what we do with that information. And first, I'd like to look at it from a public health point of view, and then how we make sense of this and work with individuals, with our patients. Sandra, can you share with us some of the potential ways that this can be addressed from a public health or public policy perspective?
Yeah, so from a public health perspective, I think a big part of this involves tackling the availability and acceptability of these products in the public today. At one end of the spectrum, this can actually be done by focusing on the supply side, by encouraging companies to focus on the development of healthier options. But we also know that this is much easier said than done. A big reason why these products are on the market is because they're actually profitable. People buy them, people like them. And so companies aren't always going to be inclined to change the way they do business if this is actually working out for them. But also related to the supply side, it would actually help if healthier food options were more available. But this also means not just available as in physically available and in near where people live, but also relates to the accessibility in terms of price, the price of healthy food. The fact remains that foods with refined carbs and sugar are just cheaper. They also last longer in terms of shelf life. Thankfully, there are actually some strategies that are being applied in the public health field and also being tested, especially where I live here in New York City. Just as an example, the New York City Department of Health has actually applied a number of public health interventions, and one of which involves stocking small corner stores or bodegas with healthier food options. And these healthier food options sit alongside some of these more refined carbs. So this is just one approach to improve the availability of the healthier food options. Another strategy that sort of the Department of Health has also used is what's called the Green Cart program. And what they do is incentivize small food carts to sell fruits and vegetables, especially in neighborhoods where there's less availability of these food items. So this is just speaking more about sort of the supply side of things. Then there's the other end of the spectrum, which is the demand side or the consumer side. And so one strategy that's actually been entertained and that's actually been applied in some settings, and especially in other countries, is to actually just make these products, the refined carbs and the sort of sugary products, just to make them more costly through policies like taxation. And again, this is being done in a number of countries and it's being tested to see if there's any sort of improvement to diet as a result of these policies. Other policies include better public health marketing or food labels. Again, these are being tested in other countries. It's tougher to test these sort of interventions in the US, and a lot of it has to do with the culture here and some of the politics around that. But these other countries are providing a nice sort of laboratory setting, if you will, to try to test the impact of some of these other strategies. And then finally, there's also the idea of just improving nutritional education or improving nutritional literacy. I don't focus as much on this because I actually tend to believe that much of the public knows what they need to do to eat healthier. But I do think there's some challenges around understanding what it means to eat refined carbs. I think people know that they shouldn't be eating lots of sweets and lots of quote unquote junk food, but there's also lots of refined carbs or foods with added sugars that people may not be as familiar with or may not know about the health consequences of some of these products. And then finally, I don't want to finish without adding sort of this one other public health strategy, which is actually not really often discussed in the context of nutrition. And it's actually mental health, or finding ways to improve mental health more generally. And one of the reasons is because sometimes these foods, like refined carbs and sugars, do actually help people feel better, or at least in the short term. There's a lot of addictive properties, a lot of biochemical properties that do, spike. You have these feelings of just feeling better. And certainly in times of stress or anxiety or depression, sometimes people opt for these types of foods to feel better. They may know that these foods are actually not good for them from a physical standpoint, but they do make them actually feel good, at least temporarily. And another approach that, again, is not often discussed so much is really addressing the mental health aspect while also helping people come up with maybe other strategies to feel better, but that are also healthier.
That is such a wonderful overview, Sandra. Thank you. It strikes me as I'm listening, would you say there are parallels between some of the approaches here and what was used with tobacco? Taxation of cigarettes brought down the demand. My understanding is that was important. I know in Canada, I was struck when I went up to Canada a few years ago for a fishing trip, and I was in a store and I saw the pack of cigarettes and the huge safety part. A third of the pack is this ugly, different varying ugly images, bad lungs, someone with missing teeth, something that ours here in America, these little disclaimer on the side. In Canada, it was a much more robust warning. Are there things that we learn from there?
Yeah, so I think a lot of these strategies are being applied from the experience of tobacco and cigarette smoking. And some of these strategies are the ones that I just mentioned that are actually being tested in other countries. You mentioned Canada. I'm actually I'm a little more familiar with what's happening in Latin America and many of the Latin American countries. And some of the labeling there is really in your face. And it's really about, this is really bad for you. You shouldn't eat this. And the labels tend to cover the packaging, so you really can't miss it. And so these are strategies that are being tested. Again, they are being adapted from the tobacco strategy. But I think what's also different and harder in many ways is that we don't need tobacco to survive, right? We need food to survive. And that really makes it much harder. And also, in addition to everybody needing food, so you can't just abstain from eating some of these foods, it's also not always clear what's a food with refined carb. There's also foods that have varying degrees of refined carb. It's not a yes or no thing, right? There's more of a spectrum, and trying to get people to understand that is extremely challenging. And I think it is what makes it much more difficult to really know what to do about the situation with nutrition and food, because again, with tobacco, you just don't do it, or say that this is all bad, don't eat it, or don't smoke it. But with food, there is much more of a spectrum. And if you have a little bit of refined carbs here and there, it's probably fine. And so that also leads us to some mixed messaging too, that makes it harder for people to really know what to do.
Those are really excellent points. And that's the perfect segue, of course, to Marina, what you're here to talk about, which is, it's clear we've gone over the different contributions, some public health approaches, but when you boil it all down for us as clinicians, how do we make all of this complicated stuff reasonable both to understand for patients on an individual level, and how do we address this? If you would share some of how you approach the issue of dietary change, and particularly your suggestions with regard to helping patients decrease sugars and highly processed carbs in their diet while paying attention to what Sandra said, that food needs to be enjoyable for us, something that is good for us, that is a part of our culture for many of us, something we enjoy.
So I think as clinicians, we love the data. We're interested in the nutrition and the research. But I always say that people don't eat nutrients. We don't eat calcium. We don't eat the iron. We don't eat the carbohydrate. We eat food. And the second point is research has shown over and over, this really interesting studies done by IFIC Consumer Research, that there's three main reasons why consumers buy food. Number one, taste. Number two, convenience. And then number three, it could potentially be health. And so I think as clinicians, we want to start off with the science. We're like, the science is so important, and we're geeking out about this randomized study. And most people are not as interested in that. And I think when we're using those strategies and when we're telling clients, this is good for you, or do this, or avoid this because it's good for you, it doesn't resonate with clients. And I think we need to start giving them solutions that don't sacrifice taste, that don't sacrifice convenience, because I'm a mom, I have type 1 diabetes, I need convenience in my life. But I think the third one and most challenging is that also don't sacrifice nutrition, right? It doesn't have to be one or the other. So I think that's the challenging part, I think, as clinicians, is how do we give them realistic advice that is not just, oh yeah, you need to avoid that because your blood sugar, your A1C is going higher and higher. You just need to cut back on the carbs. I think we could do a little bit more. So one of the things that I would start off is, do they even understand where this maybe hidden sources of sugar are coming from? And I would venture to say that most people think they have a good idea, but I think that in reality, they just don't know where maybe sugar is coming from. And I'll give you an example, because somebody said, I think Sandra, was nutrition literacy, right? Do they even know how to read a label? They might know certain parts, but not necessarily other areas. And so I'll give you an example. Yesterday, I was with a friend of mine who tells me, oh my God, I've been gaining weight and I'm concerned and I'm trying to go a lower carb diet. And so I bought this almond milk because I'm trying to lead a healthier lifestyle. And I look at the label and there was 16 grams of added sugar. And in her brain, she was thinking, I am choosing the best alternative for me, not really realizing or understanding where in a practical everyday situation, maybe these sources of added sugar are coming from. So I really do think that maybe most consumers don't know in real life. They know that we need to consume more fruits, more veggies, but when it comes to the supermarket, because Neil, it happens to me. Like, I'm the nutrition expert and sometimes I get confused. And so I think there's still a lot of education that we need to give our clients on, okay, let's see what you're eating. What foods do you enjoy? Not just sugar sweetened beverages or the beverages, but other foods. So whether it's maybe some condiments, right? Whether it's maybe some breads, whether it's secret sources of sugar in drinks that you didn't think had. So I think it's knowing where is the first point. And the second is teaching them alternatives. So I am a big fan of using natural sugar, whether it's dried fruit, whether it's fresh fruit, whether it's even 100% natural juice. That I made a pumpkin bread yesterday and I used orange juice. So depending if they do have diabetes, if they don't, if we need to be mindful of carbs or if we don't, I think there's strategies on teaching patients or clients strategies that are still going to taste good, that could still be convenient, and that are enjoyable. Because if we're only focusing on strategies that are avoid, don't do this because of health, we're not giving solutions. And the last part that I will add, and it's something that Sandra was talking about, is the relationship that we in America have with sugar. And I think as a pediatric dietitian, I work mostly with kids and families. And I think part of the problem, not all of it, is sometimes our own challenging relationship that we have with sweets. And if we're misbehaving, or we might be quote unquote sinning, and we're going to go with the chocolate. So when I'm stressed, I'm going to go and binge eat that ice cream because I never have permission. So I think those relationships of I'm eating bad are so ingrained in us. And we often believe nutrition is this black and white, that I think part of that could be part of the problem, that every time I do have sugar in front of me, guess what? I don't know how to handle it. And so I'm going to go overboard and I'm just going to binge. That's what I hope to teach in my new generation, in my parents, especially coming from a person that lives with type 1 and that was told repeatedly that sugar is quote unquote bad. How can you teach this new generation to even have a positive relationship with sweets? That it's not going to be all the time, but when you do have it, you're going to have the real stuff and you're going to enjoy it.
Marina, I always love listening when you share information. And I'll tell you, if my practice was closer to your practice, I think I'd be sending half of my practice to see you. That's such important information. Any thoughts, Vasanti or Sandra, that as you're listening to Marina?
I actually was just going to throw in that as I was listening, it's like, you're right. You're totally right about all these things. And it's interesting because sometimes it feels a little bit at odds from the public health perspective, which is all about one type of messaging for all, right? This is don't do this, do that. And it's often a don't do versus do this kind of thing. And I feel like it's not working, really. And so I almost feel like, too, just the way we do things in public health, we have to be able to add a little bit more nuance into our messaging. We have to meet not just people, but populations where they are. Sometimes it just takes different kinds of messagings for different kinds of populations, depending on their context, their culture, background, including genetic background, and that sort of thing too. And so that's something else that I think from a public health perspective that we need to think about, is that sometimes this sort of more patronizing, don't do this type of messaging is just not resonating at all. And we have to think about new ways of delivering that messaging that is a bit more, less one size fits all and more about tailoring to different groups of people.
That's a really good point. It's interesting. I want to shift gears a little bit toward, Marina, you talked about one of the things that we care about is taste, and saying, give up all your taste, just while it might be a great idea, doesn't really work. And that brings up the issue of non-nutritive sweeteners, often called artificial sweeteners. And in our first podcast of this particular series, we talked with Catherine Appleton, who is first author of a meta-analysis that looked at both randomized and observational studies of non-nutritive sweeteners. And I refer our listeners to that podcast if they're interested in a detailed discussion. But the short summary is that short-term randomized trials up to 6 months or so, even a little bit longer on some of them, showed that non-nutritive sweeteners led to weight reduction when compared to sugar in the diet. Yet observational trials don't show a long-term benefit of non-nutritive sweeteners on weight, and in fact show an increase in BMI and obesity in people consuming non-nutritive sweeteners. And again, I'd encourage our listeners to take a listen to that podcast because there's all sorts of methodologic issues, and it's a worthwhile listen. But my point there being, for today, this can be really confusing, both for our patients as well as for clinicians when it comes to advising patients. And I want to share an anecdote that occurred recently in the office and interested in everyone's thoughts about how to handle it. So I had a patient who had poorly controlled blood sugars. And I asked her, as I always do, about her diet. And she actually was very careful about what she ate. And then, as I sometimes forget to ask, but this time did, I asked her about what she drinks. And she shared that she was drinking one of the supersized cups that you get at the store, those big cups of soda, and then also 2 cups of organic cherry juice because a friend of hers told her that cherry juice was healthy. And both of those have a lot of sugar in them. So I mentioned to her the option of drinking water instead, or maybe water with a squeeze of lemon, but she didn't like the idea of giving up her current drinks. She loves her soda. I said, how about instead of drinking sugar sweetened soda, how about a diet soda? And she said that she heard diet sodas can cause cancer and that they're bad for you. And my question for all of us is, bringing all of this big data down to the individual level, how do you go about advising this patient? And let me ask Vasanti, you first, then Sandra, and of course, Marina, if you can bring this all together, because that's what you do all the time. Vasanti, your thoughts?
Yeah, absolutely. And I think this is a really interesting anecdote that you're sharing that I think many clinicians probably encounter. And particularly with the non-sugar sweeteners, you're likely aware that the WHO released a statement about non-sugar sweeteners last year. And I think there's a lot of confusion, even more so now after the release of this statement. Along with that statement, there was another statement released by IARC, which is the International Agency of Cancer Research, focused just on aspartame, which is one of the non-sugar sweeteners that's used in a lot of products, a lot of beverages. And so understandably, I could see why your patient was concerned, taking pause about consuming soda because of a potential cancer risk. That's what the IARC was evaluating. They were looking at the relationship between aspartame and cancer. So this was in the media. And so I think many people have this fear. And, coming from an epidemiology perspective, and knowing the evidence linking the non-sugar sweeteners and diet soda to health outcomes, I do really think that there's a lot of methodological concerns in those long-term studies that have made it really difficult to interpret the evidence. And so in a simplified way, I would talk to this patient and let them know what the deal is with that WHO, with that statement, and with the assessment of aspartame as well. Looking at that evidence base linking the diet sodas to health, it's inconsistent. But when we look at the trials, we're seeing benefit when they're being consumed in place of the sugar. And then we get to the long-term studies, which you mentioned, that are showing adverse effects that they can even cause weight gain or cause development of diabetes and heart disease. And it's those studies where there are the methodological concerns, where there's steps one can take to address those concerns, and we can see some of those inconsistencies getting ironed out and the data kind of converging to be more aligned with what we're seeing in the trials. But that said, there's certainly a lot more evidence or a lot more studies that are needed, particularly looking at cancer. And so the WHO statement was really focused on those long-term studies where the methodological errors are. So this is reverse causation, which you might have gotten into in that previous podcast that you did. And then the assessment on aspartame was really just focused on the fact that there isn't much evidence out there. So it's the lack of evidence that resulted in that sort of the claim of aspartame being linked to a cause of cancer. And I would discuss the evidence as best I could with the patient. But in terms of their sugary beverage intake, I would also talk to them about that and about why that's a concern, and then the strategies to try to cut it back. And I agree with Sandra and Marina's comments that you might not want to go with the whole restrict, but try to cut back and really approach this with taking small steps, right? How can you reduce the intake levels a little bit? Replace it. I would reassure them that it is safe to replace the sugary beverage with a diet beverage if that's what they're interested in for the short term anyway, because the goal is to really move towards an unsweetened beverage. Maybe the diet beverage could help them get there. Talk to them about reducing the quantity, having it maybe not every day, every other day, and then maybe once a week, and gradually trying to decrease intake of the soda. And then same with the cherry juice. It's about trying to cut it back, not 2 servings a day, maybe 1 serving a day, and maybe cutting that with a little bit of water, diluting it with water, and slowly decreasing it to get it to an intake level where it's not so much of a concern. And something I would also ask them is to try to understand why they're consuming the beverages. What is it about the beverages that they're enjoying? Is it the flavor, the sweetness? Is it the carbonation? Because I know you suggested having water with a twist of lemon, but there are a lot of carbonated seltzers out there that could also, if it's the carbonation that they crave, that it could help meet that craving. So I think I would discuss some of those other options as well.
Those are such helpful points, both the practical ones for the patient as well as the overview of all these statements that have been coming out. Thanks so much, Vasanti. Sandra, your thoughts?
Yes, in many ways, a lot of what I was going to say really echoes what kind of Vasanti just said. And it actually uses a public health lens, but applying it to the individual in the sense. And so it's really 2 things. So one is just understanding that mechanism of why she needs to have the soda every day. So just like Vasanti said, just understanding, is it the carbonation? Is it maybe she has that soda with friends and it's part of a social outing, right? Trying to understand what's the setting that makes that sort of behavior enjoyable to the patient. And then what can you do to replace that with something that's a little bit more healthier? So really, again, understanding the mechanism, understanding the why behind that behavior, I think is one approach. And then the other approach that we use a lot in public health is the harm reduction approach. And it also echoes a lot of what Vasanti had just said too. And it's about taking those small steps. So not saying don't drink the soda at all, but maybe getting a smaller cup. You don't need the large, maybe not necessarily the large, but maybe start with a much smaller serving or just 1 serving and slowly dialing it down. A lot is known about sodas and how addictive they can be. So it actually is probably really hard from a biochemical standpoint to just stop drinking those items. And so withdrawing from it very slowly and using that more harm reduction approach might be another way to go in dealing with the patient.
That's such an important concept to remember. Marina, your thoughts?
I think this is the beauty of where individualization comes into play, right? And what may work for one doesn't work for another. And I would start off first by addressing the elephant in the room and wanting to understand a little bit more. Oh, so tell me what you heard about these studies in terms of cancer and the research. I think our job as clinicians is to either translate some of this research, as Vasanti was saying, is this is my understanding. This is what I know. Really, the studies that were done were deficient in A, B, and C. Just giving it our own perspective because we have this experience and we're sharing it to our clients, and they themselves can then take those decisions, right? My job, contrary to what my people believe, I'm not the food police. I'm here to educate my clients on what we know from the research and just help them make better decisions for them. So for me, it's clearing up this myth or this misunderstanding. Also, even pointing out, okay, we have uncontrolled blood sugars on one hand, and then on the other hand, we have a potential risk of cancer. And so which one takes priority? And what we know from the research, a lot of interesting research and lengthy research on diabetes and uncontrolled diabetes. So we can take that route. A little bit more gloomy, but I would definitely say, yes, go ahead and have that diet soda, because I think that living with type 1, having options is just so fundamental. The fact that a person with diabetes can enjoy a soda, can enjoy a comparative item that is just with a different type of non-sweetened sweetener, I think that's the beauty in having options. I think so. So they do play an important role. Not everybody is going to like those options. Not everybody will accept those options. But I think the fact that we do have options, they do have options, and it's up to them to say, actually, yeah, I'm going to take it, or no, I'd rather do this. And the last thing that I would say, similar to my other colleagues that were saying, was even just be a little creative. So could we do a little seltzer with some cherry juice? Could we do even some ice cubes that you do some cherry with an actual cherry? And that's what you put in the actual glass. Giving a different twist that, yes, you can still have a little bit, but in this form. And I'll explain to you the why. The why is this amount of juice might have 36 grams of carbohydrate. And so this equals 3 pieces of bread. Giving them that education. And then it's up to them to decide. If you really want that cherry juice, then it means you're equivalent to that 1 cup of rice that you would normally have at dinner. So again, it's up to them, empowering so they themselves can make the best choices for them.
Marina, I love that. And empowering patients always is a good thing. And that can be knowledge, that can be options. We're about out of time. Vasanti, any final thoughts that you'd like to share with our listeners?
Just reminding everyone that making dietary changes doesn't have to be a big, onerous, scary thing. Just approaching it with small steps, I think, is what I would, whether it be about beverages or other foods, for example, just making small changes and simple swaps, I think, can really go a long way.
Thanks so much. Sandra, any final thoughts you'd like to share?
Yeah, I think just because we have largely clinical audience, I do just want the clinicians to keep in mind that even if you provide advice and guidance to patients, if they don't make those changes, to recognize that there may be other barriers in their life that is making it difficult for them to change. Because I think sometimes we might place blame on the individual for not being able to change their diet. And so I think it's important to recognize the context that people are living in and that there may be other barriers there that's making it difficult to make those changes.
Important reminder. Marina?
Focusing on taste, on convenience, and adding nutrition. Because if we give them strategies that will make their life more enjoyable, it makes it easier to live with diabetes. I always say, make diabetes your friend, not your enemy.
Doctors Vasanti, Malik, Sandra, Albrecht, Marina Chapera, thank you so much for joining us. And to our listeners, of course, thank you for joining us on the second of a 2-part series on sugar, dietary intake, and non-nutritive sweeteners. In the first part of this series, we focused on low and no calorie sweeteners. In this second part of the series, we talked about root causes of the obesity epidemic, public health approaches, and practical ways to counsel our clients and our patients about how to cut down on sugar and highly processed carbs. These 2 special editions of Diabetes Core Update are sponsored by Heartland Food Groups, the maker of Splenda. Let me share a word from our sponsor. Turning to the Splenda brand is an easy way to help your patients reduce sugar. Splenda allows people to enjoy their favorite foods and beverages while working to maintain a healthy weight or manage blood sugars. Splenda continually innovates new solutions to reduce sugar, including introducing Splenda Stevia, a 0-calorie sweetener grown by U.S. farmers, and Splenda Diabetes Care Shakes, a high-protein shake with no added sugar. Visit Splenda.com for a complete list of products and delicious recipes for your patients. We thank you for listening. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.